Welcome to Module 2, an overview of skin layers. Let's cover a brief overview of skin layers and then talk to our expert, Dr. Milena Amato, an oculoplastic surgeon based out of Austin, Texas. You may remember that there are two main layers to the skin, the epidermis and the dermis. Estheticians are only licensed to treat the epidermis of the skin. The epidermis is composed of 5 layers: the stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and the bottommost layer is the stratum germinative. The stratum corneum is the top outermost layer of skin. Keratinocytes make up 95% of the epidermis. Keratinocytes are cells that contain lipids and proteins. They go through a process called desquamation, or cell turnover. The average adult cell turnover rate is every 28 days. The process slows with age. In the treatment room, we can encourage or speed up the process of cell turnover with retinol-containing products, or AHAs and BHAs. This could result in better skin tone, less lines, and smaller pores. The stratum lucidum is a translucent layer of cells that allows light to come through. This layer also forms our unique fingerprints and footprints. The stratum granulosum is also known as the granular layer. It is composed of cells that look like granules, and they are full of keratin. In this layer, enzymes dissolve the structures that hold cells together. As these cells become keratinized, they move to the surface and replace the cells shed from the stratum corneum. The stratum spinosum, also known as the spiny layer, found here are the Langerhans immune cells, which protect the body from infections by identifying foreign invaders. Keratinocytes and melanocytes work in synergy here, forming the even placement of pigment. The bottommost layer of the epidermis is the stratum germinative. This is the layer where melanin is produced. Melanocytes produce pigments that not only create beautiful skin tones, eye and hair color, but also function to protect us from the sun. Every person has approximately the same amount of melanocytes. Differences in genetic color are due to the amount of melanin that is activated in the skin and how it is distributed. Tyronase is the enzyme that stimulates melanocytes and thus produces melanin. Products that suppress melanin by interrupting the biochemical process are often called brighteners, or more technically, tyronase inhibitors. Let's take a look at our interview with Dr. Milena Amato. Good morning. I want to welcome to our discussion Dr. Milena Amato. She's an oculoplastic surgeon based out of Austin, Texas. We're so happy to have you here today, Dr. Amato.
Thank you, Ashley.
And I had the pleasure of working with Dr. Amato for a few years, and so I learned so much, and that's really why I wanted to bring you on and talk to this group of cosmetologists and estheticians. We're under the section of skin layers, and I thought this was a great time to talk a little bit more about plastic surgery, and in your case, you really specialize in oculoplastic surgery. So can you explain to us a little bit about what you do, what your practice is like as an oculoplastic surgeon?
Sure. And first, I'd like to say I always knew you had a bright future when working with you in the past, so thank you for inviting me. So basically, oculoplastic surgery is a small subspecialty. You may or may not have heard of it before, but we're essentially ophthalmologists who have specialized in a 2-year fellowship in essentially surgery of the face and around the eyes in particular. What we typically do is cosmetic and reconstructive surgery around the face and eyes, primarily I guess in your field, it would be more like blepharoplasties, brow lifts, and mid-face lifts, and laser resurfacing, peels, and skincare, essentially.
Okay.
And then, as you want to know about my background,
Yes.
Moved to Austin 8 years ago, but I trained all over the country. I was at Stanford for surgery, Georgetown University for ophthalmology, and then actually came back to Texas for part of my fellowship, and that's actually where I had met Ashley.
Mm-hmm. Yes, well, we're glad you stayed here in Texas, and yes, like I said, I learned so much from you. So we did a lot of blepharoplasties. You do a lot of blepharoplasties. And that's probably one of the most common things you do. And sometimes as estheticians, we're trying to help people with opening up their eyes. Mm-hmm. And sometimes we've got a lot of eyelid skin there. So is that when somebody would have a blepharoplasty? What is a blepharoplasty? Can you tell us a little bit more about that?
Sure. So blepharoplasty just means surgery of the eyelid. So it could include upper or lower. I think the common term, that patients might talk about is an eyelid lift, but essentially it's when, as Ashley was saying, there's just too much skin, and there's only so much you can do with skincare or with some tightening procedures to try to take away that heaviness or that hooding. And it could range from just laxity of the skin, overhanging of the skin onto the lashes, or it could also include the layers behind it where you get fullness of the fatty tissue. And that can often be a hereditary thing. So you might see people of all ages with heavy upper eyelids. As we get older, they could talk about that they are starting to look tired and just can't get rid of the saggy bags. I have to say the Zoom boom really accelerated the surge of blepharoplasties. First of all, people were wearing masks, and that's all that people could identify people with their eyes, but also just looking at themselves on a camera. And so the lower eyelids as well. I think that there's a lot of changes that occur with the lower eyelids, with that mid-face, with the gravitational descent, laxity of the skin, puffiness, and then the tear trough, which I'm sure everybody is interested in as far as other procedures like fillers and some in skincare. But that's really when there's only so much that non-surgical options can improve. That is when people start talking about surgery.
Okay. So upper blepharoplasty, the skin is hanging over. Mm-hmm. Lower blepharoplasty, we have the bags or volume hanging over this area here, and that can be smoothed out, correct, with the lower blepharoplasty?
Yes, and that's basically done without having drawing in front of me, but just basically removing an ellipse of skin on the upper lid, kind of at the natural eyelid crease, typically, and then whatever needs to be removed behind that. As I was talking about, there's usually a little fatty pad, often in the inner corners, sometimes across the lid. What we have learned is that youth is fullness, so we've minimized how much volume we reduce, but really just kind of taking away the extra. So definitely skin removal for most patients, and sometimes fatty tissue all the way across the upper lid, but less so. I think we're just, again, trying to preserve that fullness. And so you have a line of stitches as the skin gets brought back together after that ellipse is removed, again, right along that natural crease. That tends to heal nicely along the crease. So it just kind of looks like a natural crease, maybe like a thin line at the end. And then with the lower eyelid, we do a lot of combination surgeries. If it's the fatty tissue, you can reduce the bags by making an incision inside the lid. And then I think, again, we're kind of focusing more on volumization or redistributing the fat in places where we've lost volume or we have a mid-face descent. So we can kind of cover up that tear trough by transposing the fat into that area all through surgery. It's almost like a permanent filler effect. And then what you're left with is almost like this deflated balloon. Once you kind of reposition that fat, then you often have a little skin laxity. And that incision's made just underneath the lashes. And then we remove whatever the extra skin is there to smooth out the skin that way. But I always tell people, this isn't going to be, we're not ironing out the skin. This isn't a laser resurfacing or something that suddenly all your wrinkles will be gone. It's physically cutting away some of that extra skin. And so it's reducing some of the wrinkles that way, but it's not a smoothing of the skin. And so we'll often add like a TCA peel or a laser resurfacing in addition to the surgery if we feel like that's part of the issue.
Awesome. Well, I have seen a lot of outcomes from when you've done those surgeries, and they were beautiful, and your patients' confidence just skyrocketed. So, and I know this is all, like, everything has come a long way in the most recent years. So going back to that, maybe not taking too much volume from under the eyes. I think we've all seen that before. So
and I think one of the patient had said to me, and I thought it was a great way to explain it, after surgery, and she just said, I feel like the veil of aging has been lifted and I look like myself again. So the goal is, I think, to just look like a refreshed version of yourself, then looking like a freak or somebody else, somebody you don't recognize after that.
Well, and that being said, why is it that some people's outcome, whether it's around the eyes or just, facial surgery in general, some people will just look refreshed, like they've been on a long vacation, and then other people will just look totally different, like not themselves anymore. What's usually the issue there? Is it patients wanting that, or just different styles and surgery, or both?
I think it's a combination, and I think age has something to do with it as well. So the older you are, the more lax your skin is. And so I think, if you're having cosmetic surgery in your 70s or 80s or 60s, then there's a lot of more skin that's removed, and I think it can give kind of a more pulled look. So I think you have to be very careful when you're trying to reduce the laxity without giving a person an artificial pulled look. There is kind of a style trend. Some people will go to different surgeons, especially in LA and such, who want a certain look, almost like, if you go to the opera and you've got an incision here, that means Dr. So-and-so did your surgery, and that's a big status thing. So it gets a little bit bizarre in that sense. I always tell patients, I think your goal should be, people shouldn't look at you and say, who's your surgeon? They should look at you and say, gosh, did you just have a great vacation? You look fabulous. And so I think some patients are sometimes surprised when people don't know they've had surgery, but yet they, look, they feel great. They get compliments on just their overall look, and people can't really tell. To me, that's like the ultimate compliment. And that should, in my hands, is the goal. And I will tell patients, no, I'm going for natural. That's just kind of my goal as a surgeon. But if you want to have that done look, then, there are other surgeons who kind of will offer that as well. And I think as ophthalmologists, we're conservative because we do want to protect the eyes, number one. We understand many patients, especially over a certain age, have dry eyes, and everybody's on a computer with dry eyes. And we don't want to replace, have them look great but be miserable either. So I think we do tend to err on the side of conservative.
Right, and I can attest to that. Your work looks very natural, and that issue with dry eyes is a very important one, because they end up with their eyelids being not enough volume, or placed incorrectly, then they'll have vision issues, essentially.
Yeah. I mean, you could certainly get rid of every fold, but then if you can't close your eyes, then that's a much bigger issue.
Right. Now, you mentioned peels versus lasers, that you are using those sometimes in conjunction with the surgery, the end of the surgery. When would you do a peel for someone versus a laser?
So sometimes we'll do peels or lasers just around the eyes, and of course, or offer around the face and neck as well. And I think if we're really looking for wrinkle reduction, really smoothing out those wrinkles more, then we're going to focus more on the laser resurfacing. And even with that, I tell patients, it's typically 1 or 2 treatments of laser, and you're not going to have a 20-year-old skin afterwards, but you should look 10 years younger, maybe 50% reduction in the wrinkles. So I think setting up the realistic expectations is important as well. I think the fractionated CO2 laser is just really minimizes a lot of the complications we had with like full ablative CO2 laser resurfacing, but still get some nice results. And then the peels that I use are the higher grade peel. So I will tell the patients, you can have a series of peels or lighter peels just as a maintenance. That's basically, I defer that. to my local estheticians or people that they've been working with. And I think it's a great compliment to just overall refreshing the skin. But for deeper peels, I'll do typically a 30 or 35%. It's almost like icing on the cake after eyelid surgery, where if you do a blepharoplasty but you kind of ignore the skin layer, then I feel like part of it's missed. So I'll do a peel on almost everybody having especially lower eyelid surgery as kind of part of their surgery. And it does just really refresh the skin. I mean, very mild tightening. But I think it does give kind of that finish that sometimes is lacking, with that dull skin after surgery. And same thing for the full face. If they have a lot of pigmentation, sun damage, I think a peel is a wonderful option with low downtime, a very quick process. But again, I tend to offer the heavier ones, and then I let my estheticians do, or the community estheticians focus on the others. And then with laser resurfacing as well for full face, people come in and they really have a lot of deep rhytids, then we're kind of talking more laser. I don't offer laser for darkly pigmented patients though, so there are certain safer peels I think would be for them. And again, I kind of offer a limited type. I don't think my stronger peels are also a good candidate for darker skin. So I will defer to the local dermatologists or estheticians for those.
Okay. So just to make sure I got this right, moderate, deep wrinkles, probably going more towards the laser, CO2, fractional laser. And then if it's not that so much the issue, could just be general sun damage, some pigmentation issues, even going more towards a peel. And then if they're over a Fitzpatrick 3, you're really using caution on the peels. Are we doing laser on 4s and 5s usually? No. Okay.
I am not, no.
Okay.
Not the laser I have. I think there are other lasers that are more safer for pigmented.
Okay. Now we want to protect the deeper Fitzpatricks and not give them any long-term issues for sure. So this might be a good question or a good time to ask. I wanted to get your take on dark circles around the eyes. What's really going on there? Because I think it could be a few different reasons. What do you normally see the issue is with the skin there?
Yeah, I definitely think it's a combination and it really depends on the individual. So starting with kind of the darker pigmented patients, those are often people who complain of the dark circles, but everybody can. And I think in that situation, you combine already darker pigment with some laxity of the skin, and that kind of bunching of the skin, especially around the eyes, can add to a darkening. And then as we start to get some contour changes, we start to develop a tear trough, and descent to the mid-face, little puffiness, and so there's shadowing that occurs, and so that can certainly add to the dark appearance of the lower eyelid, causing the circles. Then as our skin gets thinner, we lose our elasticity as we get older, then the underlying muscle layer is a very dark, muscular, kind of a dark red, so then you almost see that hue on the lower eyelids. So I do think it's a combination. Living in Texas, everybody has allergies, so then you add that component to it as well. And so they've just kind of had this years of kind of gradual eyelid swelling and stretching out the tissue, plus the aging changes. So I wish there was, the magic one cream that's going to take care of it all, but unfortunately there isn't.
Yeah, that's we learned in this section before that the skin on the eyelids is the thinnest of the whole body, correct?
Absolutely. Yeah, and that's often why we see these changes here versus the cheek, which is nice, thicker skin, a nice underlying volume, a little fatty tissue underneath it. So yeah. People might notice too, even after blepharoplasty, they have these big fatty bags. And then once that fat is removed, they may be more aware of kind of darkening appearance of the lower eyelid area because that buffer of that light fat is gone.
So that fat was kind of above the muscles and veins, kind of.
I think it kind of
concealing it a little bit
of the fat, but also just the kind of puckering out is again, it doesn't cast that shadow or that light as well.
Redistributes the light. Okay, very good to know. So besides fine lines and wrinkles, what does the face do with aging? What are some other things that happen to the face as we age?
So a lot of things. So basically we've learned that kind of every layer of the face is affected. And so of course with the skin laxity, thinning of the skin, and talked about the fine lines and wrinkles, that's just kind of on the surface that we're seeing. But then we'd also get a loss of volume. So this underlying cheek structure, the fatty tissue, and even the muscle layer can thin. We can lose some fat. We distribute the fat. I mean, gravity's not our friend after 50, I tell everybody. So, we start to see descent and sagging of all the tissues, not just the skin. And then we've also learned that, we do get some bony loss. Actually, I have a little skeleton here. So the studies show that actually the inferior orbital rim, we get some volume loss there. The maxillary bone, so sometimes that mid-face volume loss here, and even right along that area where you see it, right on the area where we see some jowling, we often get some thinning of this bone, and even in the piriform process of the nose. So you take a combination of skeletal changes, overall volume loss, and the skin laxity and fine lines, and with gravity, and that's, I think, where you get the overall aging changes.
Yeah, there is a lot going on several different layers. Thanks for explaining that to us.
Mm-hmm.
So let's see here. I also wanted to ask you, how can estheticians aid a plastic surgeon in pre and post-op care?
So I think there can be a lot of communication between patients that would be really helpful for the patient. Again, I think just preparing the skin before surgery, peels, whatever it is that we're planning to do, is always helpful. So I always do ask, what's your skincare routine? Do you have an esthetician? Do you see somebody for your kind of non-surgical issues if they don't come to our practice? And then, they often do. They often do have somebody that they work with. And if they do, they're already on a pretty good regimen. If they do not, then I do encourage starting them on some type of skincare. And that's where I think estheticians will really be helpful. And then also working with them. So if an esthetician is seeing a patient and they're having fillers or Botox or other procedures, then I'll ask when their last treatment was, and then maybe make a recommendation of, if you're going to have surgery, don't have any more fillers at this point. Or sometimes I even like Botox to be in place before a brow lift, because I think it just minimizes the kind of counter force that scowling can do while you're healing from a brow lift. So then I'll actually encourage the patient to go back and get their Botox from their esthetician just prior to their surgery. So again, working together, I think, is actually helpful. And then also just with the healing, I think there's so much that can be done with making sure that they are on a good skincare regimen. Right after surgery, it's just ointment and healing for a couple weeks. But then I usually ask them to kind of bring all their products with them after surgery, so we can start putting them back on products. And if they're pink after a peel or after a laser, then if they're not on like a vitamin C serum, I'll ask their esthetician to kind of add that to their regimen, and then kind of get them back on their Retin-A's or add the Retin-A's. So there is, you have this wonderful, beautiful result, but then you also want to preserve it and maintain it. So if they just leave and go home and don't, continue this, then I think that the recurrence and kind of the onset of the aging process is much faster if you're not maintaining the skincare. And then also just, I have relationships with estheticians who'll still say, Miss So-and-so's here at month after surgery, she's pretty pink, how about adding this? Or, how about some microneedling on this scar? And then we'll have them kind of work on that. So I think there certainly can be some ways to complement what we do, and then just to kind of maintain afterwards. And I encourage patients to go back afterwards for kind of maintenance.
Absolutely. Now, would you say that if someone is seeing an esthetician, getting their skin in kind of optimal condition before surgery, that's helpful in their healing kind of in the long run?
Absolutely, and especially if they're going to be doing things like peels or laser resurfacing. But even for just overall skin quality in the healing process, I'm always concerned about the scar itself, but I do find that if patients are on a healthy routine, they tend to have just, first of all, better understanding because they've been educated by their esthetician. And some patients would then say, I had a pink scar, so I used the vitamin C that, they had given me and started using that. So I think educating the patients is really key too, that it starts with the esthetician.
Okay. So another question for you about injectables versus surgery. Can you give us a little bit of an idea of when, because I know it's not just a number, an age, when is injectables going to be helpful, or when would it be an occasion where it's really time for surgery over injectables? Because sometimes patients aren't ready to hear the word surgery.
Right.
So how might we help them maybe know which direction to go, and also talk to them about that?
Yeah, so when I do a cosmetic surgery consult, I always kind of start with the non-surgical options and kind of lead to the surgical options. Just like you said, sometimes I'm not sure where they stand. They may be coming in for an eyelid lift, but they probably need mid facelift and brow lift and everything else. So that's kind of daunting. So kind of starting small and kind of educating them and giving them all the options, I think, is always helpful. But there's a role for fillers at many ages, and there's a role for surgery at many ages. And I think when there's a lot of laxities, or just too much skin over the eyes that we talked about, or just it's more dealing with kind of the looseness of the skin, a significant amount of rhytids and wrinkles, then I think that's where we're talking more surgery. I mean, joweling, we know from fillers can be improved. And there's a lot of volume loss that we see with aging, and that's certainly where fillers can play a role. I do like with the mid-face, there's so many better fillers out there now that last longer. So I find myself talking patients into more of a filler than like a mid-face lift. Because if you're going to get an effect for even a few years of a filler that can be done in the office, then I think that's going to be kind of age more naturally with the patient than something that's a surgery. And I think a couple of years is, a great amount of longevity for a filler. So that's kind of more, we're still working on around the mouth, and, fillers kind of go away pretty quickly, but I also use fillers as a complement. So we'll say, with the mini lifts, we can certainly improve those jowlings. But then, as you heal, we'll probably enhance or complement it with some fillers too. So I also use it as a complement, not really a replacement for one versus the other.
I see. I wanted to ask you, I'm kind of throwing this one in there. This is about smoking. Earlier in this module, we talked a little bit about the effects of smoking on the skin. So if you have someone comes to you, needs their one surgery, and they are a smoker, do you have a discussion with them about that? Is it okay to do these kind of procedures, like surgery around the eyes of someone smoking every day?
Luckily, I don't know if there's just less smokers in the world, or maybe they're all vaping, I'm not sure. But we still certainly have those patients, and we always check. There's certain surgeries I just won't do on a smoker. Like I won't do anything with a flap. Flaps are just large areas of skin, like in a mid-facelift or facelift, that if you smoke, you can certainly kill the blood supply to the periphery of that flap. So I will discourage them from that type of surgery. With eyelid surgery, it's not that you can't do it with on smokers. Eyelids have probably the best blood supply of any part of the face, so we tend to have less issues with healing with smoking. But I tell everybody you're going to have probably irritation of the eyes more so. The healing's going to be slowed and delayed. You might have more swelling. So, it really has an impact on the immediate healing effect, just whether it's from the vasoconstriction, from the nicotine, as well as just the smoking environment to the comfort of the eye. So definitely find out anybody who's smoking. I did have a patient who called like the night before surgery, and she said, "Oh my gosh, I had 3 cigarettes today. I didn't realize, I read somewhere you're supposed to stop or you want to do surgery." It's like, well, I prefer that you don't smoke, especially after surgery. But this, you're having an upper eyelid blepharoplasty. So I explained to her what the risk would entail, and she wouldn't move forward with the surgery, but and she just kind of missed that information. But most people, we tell them everything at that consultation. There's just some things that patients just don't process. So that was one of them.
Okay. So overall, definitely a better healing outcome if they stop smoking.
Yes.
Is there a period of time that you're shooting for? Is it just like they can stop a day before and then get their surgery, or are you looking for a few weeks to be in between? Or I'm sure the longer the better, I guess.
Typically 2 weeks before and after, essentially. And then depending on how they do, because I'll, especially for kind of the facial incisions, I'll see them between week 1 and 2 after surgery. If they look pretty healthy, then 2 weeks is reasonable. But if there's any signs of ischemia at all, then we're going to extend that no smoking further until we feel like that flap is healthy.
Okay. Yeah. So my last question this morning, what are your recommendations with skincare? Just generally, what do you want your patients to have in their home care typically?
So I usually tell everybody that you should at least have a good sunscreen and moisturizer. If you're going to choose 2 products, then I think that's going to be the top 2. I tell all men this, all women, even the ranchers, people you don't think would listen to you. But I think that those are the things, the hydration and the sun protection, especially living in sunny places like Texas. And then after that, we start to get into all the different layers of antioxidants and cell turnover. So, and that's where we were talking about the vitamin C's and antioxidants, then the retin-A's, the glycolics for the cell turnover, and now the newer hyaluronic acids and HAs. So, this could be an entire conversation on skincare. So, and so I do, we offer kind of a limited amount, but covers all the facets of type of skincare. We do have some treatments for patients who might hyperpigment after these lasers or peels. And of course, that's a whole other population of patients that we have to be mindful of. Because anytime I'm working on the skin with a peel or laser, we have to be prepared for either prevention or treatment of things that we might see from post-inflammatory hyperpigmentation or inflammation. And so, like I said, we kind of have a limited amount that covers all of that. But again, if they're working with an esthetician or a dermatologist already, then I'm just working with them to make, giving them the timing as far as when they would restart all these products. But again, I do tell patients, don't you want to maintain and preserve the effect that you've had after surgery? So if you're not taking the skincare regimen, then really consider it. And then, this is how you can do it. So I kind of like to have them kind of get them back started on things, but I do love to pass them off to people who really just focus on the maintenance of it, and we get ready for the next surgical patient.
Awesome. Well, we will keep those things in mind, and especially the part of, again, how we can help prepare a patient's skin for surgery and how we can help afterwards with skincare to really maintain their results.
That's very beneficial. I appreciate that.
Well, thank you so much, Dr. Amato. I feel like we really got a great inside look at facial surgery, especially oculoplastic surgery with you today. This is really valuable information that we'll definitely have in our minds when we are with our clients and patients in the treatment room.
Well, thank you very much for including me.
Of course.